Hi everybody and welcome to Evening Rounds. I'm Dr. Jayme Castillo and I'm an assistant professor in the generalist section of obstetrics and gynecology at the University of Chicago Medicine. But I do spend about 20% of my time now with the section of reproductive endocrinology and infertility, which is why today's session will focus on infertility. And we'll be covering the definition of infertility, the general workup, and a brief overview of some treatment options. And this session is part of our continuing education series for OBGYN nurses and medical assistants. Here is the U Chicago mission and core values, as we all know. And then I do not have any disclosures. So again, the plan tonight is to give a little overview of fertility and infertility, including how we counsel patients who desire to be pregnant, what labs and imaging studies may be ordered for an infertility evaluation and what they mean, and ending with an overview of common treatment options. And I do tend to talk a little fast, so we may end up with some extra time here at the end. So, starting with some definitions, sorry to be boring, but the definition of infertility is the failure to achieve a successful pregnancy in 12 months of regular intercourse, although you can evaluate and treat patients after just 6 months if they have fertility risk factors, the most common being age over 35. We know that ovarian reserve, or how many eggs are left in the ovaries, starts declining more rapidly after 35, and the risk of abnormal pregnancies that result in miscarriage also increases after 35. So time is of the essence for patients who want to build their families, and we can start that workup a little bit early. Infertility is interesting because sure, we may know that someone has risk factors for infertility, but the only way to have a diagnosis of infertility is to actually try to conceive or try to become pregnant. And then just some semantics is that primary infertility refers to a patient who has never had a successful pregnancy or and then secondary infertility refers to someone who has had a prior successful pregnancy or who literally has a child already, but for whatever reason is now meeting criteria while trying to conceive again. So how many couples do we expect to become pregnant in that typical year that we recommend timed intercourse for patients under 35? If you thought 90% of couples in your head, then you would be correct that that answer is about 90%. This chart here comes from a paper published in the early 2000s that looked at over 300 couples trying to conceive with timed intercourse. And we can see that at 6 cycles, and I'm not sure if you can see my cursor, but down here on our x-axis, 6 cycles are roughly 6 months. We have about 80% of couples who are pregnant. And I think it's important to point out that at 3 cycles or 3 months, over 55% of those couples are already pregnant. At 12 cycles, or roughly that year mark, we get that extra 10% from 80 to 90, with 90% of couples having a pregnancy. And then after that year mark, up to 21 months, we don't get much more gain. So in general, about 10% of couples end up struggling with infertility. When we think about how we counsel patients who desire pregnancy, we recommend this timed intercourse, which essentially is code for strategizing having sex in the fertile window. And the fertile window specifically refers to the 6-day window that ends on the day of ovulation, aka the 5 days before and including the day of ovulation. And on our little graph here, we can see that the day of ovulation is marked as a 0 over here. And again, I'm not sure if you can see my cursor, but just go with me. With the highest chance of conceiving in the days prior to ovulation, and then a very, very low chance of pregnancy if we miss that window prior to ovulation. So it's pretty important. Um, there are a number of ways that patients can try to track their fertile window that you may have heard of, including in my opinion, the more popular methods that patients choose, like calendar tracking or using ovulation predictor kits. And then there's also in my opinion, again, the less popular methods, which are basal body temperature tracking and cervical mucus monitoring. And I thought we could take a quick second to talk about some of these tracking methods. The first is tracking with the calendar, or more commonly now an app. The apps like Apple Health or Flow, or probably a million other different apps that you could find on the App Store, all use their own algorithms about the lengths between tracked periods to help predict the day of ovulation and the fertile window. And this can work really great for someone who has a very regular menstrual cycle, but may not be very accurate if someone has a more unpredictable cycle. Ovulation predictor kits, or OPKs, as they're also known, are often used alone or in addition to calendar tracking. OPKs measure urinary luteinizing hormone, or LH, and LH surges about 24 to 48 hours prior to ovulation. And we can see that in this little depiction of the menstrual cycle hormones here, where our yellow line is our LH surge going up right around here, maybe day 12-ish, and our day of ovulation is day 14. So knowing when that surge happens can put us right in that highest probability for pregnancy window. One example of the ovulation test strips that someone may have are shown here on the left. And I always ask patients to please read the instructions because oftentimes people will think, oh, this is really similar to a pregnancy test. And it is, but different from a pregnancy test. An ovulation predictor kit will often have two lines that are dark, but that doesn't necessarily mean you're at highest fertility. So it's really a how dark is that line that indicates the highest fertility. So down here, you can see that this is our darkest line matching our control, and they're saying that is the ovulation window. Oops. Next up is basal body temperature tracking. Temperature rises secondary to progesterone production, which is released from the corpus luteum in the ovary after ovulation. The rise is only about half a degree and requires a special thermometer with an additional decimal point that you can kind of see here. Patients are told to take their temperature as soon as they wake up, which would ideally be around the same time each day and before they have anything to drink or go to the bathroom or do anything else. The big drawback is that the temperature rise is associated with progesterone, which means it occurs after ovulation. So it's helpful to look back and determine when ovulation may have occurred retrospectively, but not so useful for couples who are trying to get data in real time to plan their intercourse. And lastly, we have cervical mucus tracking, which is a strategy where people do just that. Patients can look at discharge on their underwear, on toilet paper. They can collect mucus with their fingers. And increased estrogen right before ovulation leads to an increased volume of mucus and more slippery or clear mucus that you can see in this day 10 to 14 area of the graphic. And that tells you that you're in the fertile window when it's actually happening, as opposed to the basal body temperature tracking. And then cervical mucus is obviously the cheapest option, although there might be a learning curve, and it doesn't require a special thermometer or a bunch of test strips purchased from the pharmacy. All of these options can decrease time to pregnancy, but they can also put a lot of stress on couples, which is something that we should try to be mindful of. So going back to those 10% of couples who need evaluation, well, what exactly are we evaluating? And we know that to have a pregnancy, we need eggs in the ovaries, ovaries that ovulate, sperm with normal concentration, normal motility or movement, and normal morphology or shape. We need fallopian tubes that are open so the sperm and the egg can meet, and a uterus that's a nice place for a pregnancy to implant and grow, and for patients to generally be in good health. Our testing for infertility cast a wide net to find the cause and looked at all of these specific components that we mentioned. The testing for ovarian reserve, or how many eggs are left in the ovaries, includes both lab work, including an anti-Müllerian hormone and follicle stimulating hormone to see how hard the brain is working to send the ovary through the menstrual cycle. And then we can also use a transvaginal ultrasound to obtain an antral follicle count, or AFC, which is essentially how many eggs start to be stimulated at the beginning of a menstrual cycle before that dominant follicle takes over. Um, Patients who we might be concerned have a lower ovarian reserve could be patients who are older, who've had surgery on the ovaries, like a bunch of cystectomies or cyst removals, or even perhaps an entire ovary removed or oophorectomy secondary to torsion or something like that. Patients who've had prior chemotherapy or radiation could be at risk for lower ovarian reserve or diminished ovarian reserve. And then even some genetic conditions can cause early ovarian failure, or early menopause. Next, how do we test for ovulation? The best marker for ovulation is actually having regular periods. So, a period we know happens in response to a decline in progesterone levels in the body if you don't become pregnant. But the progesterone is only elevated in the first place because it's being produced by the corpus luteum. And the corpus luteum only exists because that's what's left over in the ovary after you've ovulated. So we can do some backwards math for most people who have regular periods to feel pretty confident that someone is ovulatory. We can check when we're not sure with ovulation predictor kits that we went over previously, or we can even do lab work to check for that progesterone rise that we expect after ovulation, or get an ultrasound and see if there's a corpus luteum in the ovary. Some patients at risk for not ovulating or anovulation are patients with polycystic ovary syndrome, which is pretty common. Patients with other endocrine conditions or dysfunction, like having hypo or hypothyroidism, patients whose BMIs are so low that their brain doesn't send signals for the menstrual cycle to the ovary in favor of spending energy on other bodily processes. To assess the tubes, we can do a variety of different testing, which are all pretty similar in theory. The first is a saline ultrasound, also known as a saline sonogram or sonohistogram. It's got a lot of names, with what this institution calls a FemView, or a test with aerated saline. And essentially, what that means is we place water and air bubbles into the uterus through a small catheter placed through the cervix while we watch with a transvaginal ultrasound to see if those air bubbles exit the fallopian tubes, which is this depiction on the top right here. Similarly, a hysterosalpingogram, or an HSG, is the same contrast or the same concept, but instead contrast instead of aerated saline is placed through the cervix into the uterus, and we do X-rays at the same time to see if that contrast spills out through the fallopian tubes. And that's what's showed here in the middle picture. And then lastly, you can put blue dye through a uterine manipulator during actual surgery when you're looking right at the uterus and right at the fallopian tubes to see if that blue dye comes out of the fallopian tubes into the pelvis. And that's called a chromoperturbation. And in this bottom picture, we can see all of the blue dye collecting there at the pelvis, which proves to us that at least one of those tubes is open. And then if you're like, ouch, that doesn't sound very pleasant, you would be correct. But it is a pretty quick procedure, the saline ultrasound and the HSGs, and people tend to tolerate it fairly well. Patients at risk for tubal factor infertility or having an abnormal one of these tests are patients who may have had a bunch of prior pelvic surgery and they may have scarring or adhesive disease that kinks the tubes. Patients who have had sexually transmitted infections like gonorrhea or chlamydia, or even pelvic inflammatory disease that can scar the tubes. And then obviously, if someone has had a tube removed either on purpose for sterilization or for an ectopic that's ruptured and they need the tube removed, then tubal factor could also be one of their fertility issues. We also want to take a look at the uterus, which can be done with a normal ultrasound, with a water ultrasound or saline ultrasound for if we want to be fancy. And the water that we place into the uterus really does a good job of outlining the cavity of the uterus to show us if there's any filling defects or something abnormal that shouldn't be there and maybe not, or maybe impairing the way a pregnancy may implant. And then lastly, we could even do a hysteroscopy, which is when we place a camera through the cervix into the uterus, typically in the operating room under some anesthesia. And when we can look inside the uterus and actually see if there's any abnormalities or anything that needs to be removed. And so in this picture of an actual hysteroscopy on the right here, we can see this uterine cavity that we're inside of with the hysteroscopy. And we can see perhaps this is over here the patient's left fallopian tube opening. And then right in the middle, that shouldn't be there. That's probably a little fibroid or big fibroid that needs to be removed. And so we can remove that with a little shaver device that goes right next to the hysteroscopy camera. Um, and so patients who may have a uterine etiology for infertility are patients who have big fibroids, like this gal, patients who have had prior uterine procedures like DNCs that can cause scarring inside the uterus, which is also known as Asherman's. And sometimes patients are born with congenital anomalies that you may find for the first time during an infertility evaluation. And then lastly, we can't forget to check for male factor with the semen analysis. And so we check sperm volume or semen volume, sperm count or concentration, morphology, which is the shape, and then motility, which is how well the sperm is moving. Okay. Treatment for infertility really depends on the findings from the workup. So patients who have big fibroids, surgical intervention like that hysteroscopy or even bigger surgeries to optimize the uterine cavity. Patients with abnormal thyroid function or other endocrine issues may need medication like Synthroid or thyroid replacement to restore ovulation. Many couples will have an issue in more than one of the categories we went over, or many couples, I think about 15%, have entirely normal infertility testing, so we don't have a reason that they're having such an issue trying to conceive. The three standard fertility treatments that you'll often see in patients' charts are ovulation induction, intrauterine insemination, and in vitro fertilization. And so I thought we would also talk about those. So ovulation induction refers to using medications like Clomid or letrozole to essentially trick the brain into stronger stimulation of the ovary to try to achieve an ovulation and convince that ovary to develop a dominant follicle to therefore ovulate at the midpoint of the cycle. So these are usually oral medications that someone would take at the beginning of a menstrual cycle to try to achieve that effect. We usually start with a low dose to see if we can get an ovulation at the lowest possible dose before going up, because one of the side effects, so to speak, of using one of these medications like Clomid, for instance, is the chance of having multiples or having a twin pregnancy. So this might be a treatment for a person who really has the ovulation problem. The main one that comes to mind is polycystic ovary syndrome, where not ovulating consistently may be the only problem that is keeping someone from becoming pregnant, and all they may need is one round of some letrozole medication. The next method right in the middle here is intrauterine insemination or IUI, which refers to when sperm is placed through the cervix into the top of the uterus with a syringe just prior to ovulation. This takes place in the office, not under any anesthesia typically, and people tend to tolerate it fairly well. I would say probably easier than an IUD placement. Um, and then in vitro fertilization refers to when a patient takes medications to stimulate the ovaries prior to an egg retrieval under anesthesia. And this top picture with the little yellow background is showing an egg retrieval, where we use a transvaginal ultrasound and a tiny needle through the back of the vagina to go suction out all the eggs that were grown by those stimulation medications and into a test tube. The test tube is handed over to an embryologist who would then fertilize those retrieved eggs with the partner or donor sperm. They grow those fertilized eggs into embryos, and then once there are embryos, those embryos can be placed back inside the uterus, similarly to the IUI procedure under ultrasound guidance, placed at the top of the uterus where they hopefully will achieve a pregnancy. With all of these options, patients are monitored with labs and ultrasounds and given additional medications to really optimize the chance of conception, which is great for the end goal of pregnancy, but can also cause a lot of stress for patients and generally be not the most fun of a time. Okay, and I have talked so fast, but we're going to keep going. That the takeaway points are to have a diagnosis of infertility, you actually have to try to conceive or try to become pregnant. We know that about 10% of couples will meet criteria for infertility, but most couples will become pregnant in that first 3 months of trying to conceive. We saw that the evaluation for infertility cast a really wide net and can find anything from multiple issues to no issues at all, where we have unexplained infertility. And then the treatment for infertility is individualized and based on the findings during our evaluation. And I talk so fast, but if anyone has questions, I am happy to answer those. I'm trying to stop share.
I have not necessarily a question, Dr. Castillo, but I would say, and nurses and MAs, anybody that's on here, chime in, of thinking about what are the most common things that patients call in with, and how can they help facilitate the care for them. Um,
Yeah, I think I might be a little biased because I usually get most of my questions from the fertility space on the RAI side. And I think people often have a really hard time understanding the fertile window. And so I have done a couple of visits where someone is doing essentially natural family planning, where they're having intercourse right after the period ends or right before the period is about to start because they think that's when they should be, which is they're essentially avoiding the fertile window in general. So I think being able to counsel patients about that, requiring an understanding of the menstrual cycle, is probably the main question people ask, is if they're doing this right, are they ovulating?
I think that figure that you showed of the difference between the discharge, like if it's sticky, if it's this, where you are. I mean, I think that can really be helpful, even just for regular people calling and saying, I think I still have BV. And it's like, no, you don't. You just get a discharge. You're getting a discharge.
Fair,
I'm
fair.
like,
And
yeah,
I
we need
used
to
to,
put that on little note cards and pop it up throughout the clinic.
yes, that discharge can be normal. Yeah. Other question.
I'll call them. Natasha,
Pardon?
or Marlene or Alyssa, you guys have any questions that pertain to questions that you encounter with patients? Not to like put you out there. Well, I think that must mean you did an amazing job. I mean, actually you did do an amazing job of going through like the workup up to like what treatment options are too. I think we can give people some time back. Thank you.
Amazing. Sorry, I know I talk so fast, but you never know. We never know. And then I think that what I was supposed to say after is that the next session will be on January 19th with Dr. Nunes, and I'm not sure what topic it is, but mark your calendars.
I think
Oh,
he's going to
I
be
see.
talking. Mhm.
There's a message in the chat here. It says, with a 35-day cycle, when would you tell a patient they ovulate? So in general, the luteal phase is always the thing that's conserved. So the follicular phase or the first half of that menstrual cycle is the thing that actually changes. So 35 minus if we said 14. So this person, oh my gosh, do math for me, Dr. Christmas. What
Well,
is
if you're it's
21?
going to be about day 21 for them,
Yeah.
20, 21, 22 around that window.
About 21, because the beginning half of the menstrual cycle to make that dominant follicle is the thing that changes for people with different length cycles. But that would be someone who maybe an app wouldn't track very well for and might need some ovulation predictor kits or something funky like cervical mucus tracking.
And especially if that person is changing, where like sometimes they're every 35 days, sometimes it's every 21 days, sometimes it's 28 or maybe even 40. That's somebody that may not be, we may not be able to track as well. And they probably need to see you sooner than later.
It can be a very frustrating process for patients and families.